and it'll be over to Dr. Priyanka Chandratre to give us an update on what's happening with her study.
Hi there. Good afternoon, everyone. I am Dr. Priyanka Chandratre, and I hope you can see me and hear me okay. I have started my screen share. So I'm really honored to be here today, and on behalf of the 3 Centers of Excellence, I'd like to tell you a little bit about what we have been doing in terms of research to help improve the knowledge of this rare condition, which has such a significant impact on patients' lives. So,
Priyanka, would you like to just put it on screen view? Yep, well done. Cool.
Can you, is that better?
Yeah, well done. That's it, Brill.
Okay, thank you. So, the research that we have been doing across the 3 centres, and also including our colleagues in primary care, focuses on looking at the epidemiology of Behçet's. And at the moment, the current estimates have a hugely wide range. So as expected, places in the Middle East, for example, Turkey, the prevalence is 119 per 100,000. We've just heard from Will that the prevalence here in the UK using the primary care data was about 10, which is actually also reflected in a study that we have collaborated on using the Health Improvement Network with our primary care colleagues. Apologies, that's gone, sorry. So the prevalence here has been rising gradually, and we know that back in 1977, when there was just a small survey, cross-sectional survey of general practitioners in Yorkshire, the prevalence was 0.64, whereas now, using our thin database, it's around 14. And there are issues around case ascertainment. As we know, this is a rare condition, hence the diagnosis is challenging at the best of times. But that's exactly the reason why we need to really investigate this, including the whole of the UK, really. So we have done some pilot work to that end at the Birmingham Centre. We used our denominator data as our population of the catchment area. Apologies, that slide seems to not be working as well as I would like it to be, but our denominator is our population, which has a catchment area that is quite wide-ranging and often does overlap with the other centres. We used the midpoint of our study, which happened to be 2015, and we looked at the ONS data, the mid-year population estimate, and that happened to be 16 million. So with a larger study in mind involving the whole of the UK and starting with England, actually, at first, we felt that the following objectives would be a good place to start. We would like to look at the prevalence and incidence of Behçet's stratified by gender and ethnicity. We would also like to look at the demographic of the patients, so looking at their age, their ethnicity. We would like to then look at all the clinical characteristics at presentation and what then develops. Sorry, my slides seem to be on a timer, apologies. And also looking at the treatments and how the individual factors have an impact on the outcome. And we used regression analysis to look at the outcomes as assessed by the Behçet's Disease Activity Forum and the EQ5D questionnaire. The next step would be to look at whether Behçet's actually comes as clusters, so the symptoms and signs form clusters, which has been found in Southeast Asia, for example. So just quickly to take you through our data from the Birmingham Centre, as expected, majority of our patients had oral ulceration, 80%, followed by genital ulceration in about 63%. Followed by ocular involvement, so uveitis predominantly. Just about a third of our patients had access to biologic treatment, and majority were on steroid and some sort of synthetic disease-modifying drug. Here the data is further broken down by gender, and we can see that actually the key differences are that women tend to have more genital ulcerations, more musculoskeletal or chronic pain symptoms, and men tend to have the more systemic ocular inflammation or neurological involvement. And that would then be consistent with the higher disease activity score seen in the male population. So having done that pilot work within our centre, we then collaborated with our colleagues at the University of Birmingham, and we have done this work, which is now published in Rheumatology last month. And this looks at the Health Improvement Network, which is a database of about 3.6 million people in primary care. And this was a study over 17 years looking at the incidence and prevalence of Behçet's in primary care. The incidence has remained more or less stable around 0.6 over the 17 years, but we can clearly see that the prevalence of Behçet's has increased drastically from 7 per 100,000 in 2000 to now 12 per 100,000 in 2017. We also know that Behçet's has a significant impact on ischemic heart disease. So, for example, the risk of having an ischemic heart disease condition, that the risk was threefold in people with Behçet's compared to controls, and the risk of having a thrombotic event was fourfold. Sadly, mortality also had a higher higher risk, so that was 40% higher compared to controls. So these are really remarkable figures, and it just shows that, you know, the impact of Behçet's and the unmet need in researching this. And we know that people with Behçet's also have a significantly higher risk of having blood clots in the lungs, for example, pulmonary embolism, compared to controls. Although it is important to note that until they had that significant event, Behçet's was undiagnosed. So again, that delay in diagnosis comes into play here. So having done this pilot work, we really want to get on, and sadly COVID has delayed us a little bit, but we are raring to go now, and we know that the next steps really are to validate these findings by doing a nationwide study. And for that reason, we have collaborated with our colleagues at the University of Birmingham and within the 3 centres. And the plan is to look at the health episode statistics, which incorporates hospital admissions, attendances to A&E and outpatient appointments. And we will then use that patient identifiable data to validate the diagnosis using the patient records held either at the Centre of Excellence or within the NHS Trust. And there will be still a minority of patients who may not have had a secondary care encounter, and the plan is to trawl again using the clinical practice research database, CPRD database, to pick up those minority cases. And the aim longer term would be to use this as a means to populate a national registry, which you know, has been talked about earlier. And that would really help us to assess the impact of Behçet's centres, the 3 centres of excellence, and also look at how you know, there is equity in accessing the biologic drugs and other treatments. And I'm very pleased that this work is really well supported by Behçet's UK, who have kindly agreed to fund part of the study. And also we are applying to my base trust, Sandwell and West Birmingham, for partial funding. And we are also very fortunate in that we have support from the Commissioners for Highly Specialised Services in carrying out this work. So I hope to be able to update you a bit more next year about this. And I think the key strengths that I feel, that we feel as collectively as the 3 centres, is that this is the largest population-based study within the UK and the Western world. And it really, by sort of including primary and secondary care data and making sure that we have robust validation of the diagnosis, that this will give us a true estimate of the prevalence and the incidence. This will no doubt be very useful in understanding the disease natural history, how it impacts people, and also raise its profile. And as I've said, the ultimate aim is to create a registry, which is really badly needed, we feel. So with that, I think that's my quick update, and I'd like to say thank you to all the members and patients who come to not only the Birmingham Behçet Centre, but actually the centres in London and Liverpool. And I think that's it from me. Thank you.
Fantastic. Thank you, Priyanka. And we'll look forward to continuing working on this. Brilliant.
Thank you.
Right. Okay. Next is Rob. And I asked Rob if he'd give us a bit of a brief on how things are going now, new ways of working.
Thanks very much, Tony. Hello, everybody. Good afternoon. Welcome to my study. I never thought I'd be saying that a while ago, but here I am talking to 120 people from my study at home. And that's a really good thing in many ways. There are three important things going on today. Number one, it's Behçet's UK annual general meeting, and it's great to be meeting with you and contributing. Number two, there's a very important football match, Liverpool and Everton. I won't spoil it for those of you that want to watch it on Match of the Day, but it's a game worth seeing. And thirdly, it's my wedding anniversary. The key thing is that remote working can allow us to balance a number of things. It's good to be able to do a lot, but it's bad that I can't be physically with you. I can't meet you for a cup of coffee. We can't have informal conversations at the AGM, but we can have the AGM, and that's really crucial. So similarly, for the Behçet Centres, the three Behçet Centres of Excellence are all open for business, and we have stayed open for business. We've had to work differently. We've had no choice really. And to protect our patients, we've cut down the number of patients that we've seen face to face. And instead of face-to-face consultations, we've learnt about doing telephone calls. We've also learnt about doing video calls. There are different platforms. In Liverpool, we use Attend Anywhere, but other hospitals use similar types of platform. I personally prefer to see patients. I think it's important when we're talking with each other, we can look each other in the eye. Given some of the symptoms of Behçet's, it can be a little bit challenging to see where some of the problems are. So we wouldn't necessarily be using the camera to see everything. But what we do at the moment is to ask our patients to email across photographs of their lesions, which get stored on a secure server in my hospital. And I know in London and in Birmingham, there's a similar thing. So we try and do what we can to maximize the importance of our consultations. It's not perfect. I personally prefer to see people face to face. I like to be able to chat informally in the waiting room and catch it with people there and see everybody chatting to each other. But that's just not possible now. When we see people face to face, it's very regulated. We can't have many people in at once to protect our patients. We have to dress up in our fancy dress of PPE, but that's to protect both of us. So the bottom line is that it's not ideal, but working differently, we've learned a lot. And I think we're going to carry on working differently. There are plenty of patients from around the country and different countries that really suits them to have the consultation by video. But many more patients really appreciate physical contact, coming across, meeting with us, seeing other people with Behçet's in the waiting room, meeting with our support worker who isn't able to come in clinic at the moment. So the bottom line is we're doing our best, bear with us. We are trying to do what we can. It's a difficult situation. And certainly in Liverpool, it's frustrating at the moment because of this terrible flare and terrible surge of COVID. But we will get back. We're there for you. Put up with us a little bit longer, and then hopefully we'll be back for you. Thanks very much.
Fantastic, Rob. Well done. That's exactly what I wanted to hear from you, and I'm sure the patients do too. Right, now let's just, I asked Will to come back and give this sort of GP perspective with similar comments. So let's see what you've got to say, Will.
Thanks, Tony. Yeah, so I mean, obviously primary care, as everyone's familiar with, like secondary care, have adopted to a video and telephone first model. So, we were strongly encouraged to triage everything via video and telephone. But, certainly in my experience that was never excluding face-to-face consultations, but I still have come across patients because I work in the out of hours setting as well, who say, oh, my GP's been closed for months, I can't get in. And, you know, certainly the way that has been communicated has not always been the most helpful. My experience is that patients who need to be seen are being seen, and the opportunity to do both telephone consultation, which was already very well established, but also video consulting there's been a seismic shift with COVID-19. And although I'd absolutely echo you know, comments before that I didn't go into medicine to do everything over the phone and video. I think almost every medic I know is a people person. That's why you do this. So it is a barrier, but there are opportunities. You know, I think it has sped up the adoption of some of the digital technologies that have enabled us to do this. So I have a piece of software called AccuRx that's linked to my electronic health record. I can do a video consult through that. It records in the electronic health record that I performed that. I can send them information and links and documents straight to their phone via text message. They can send photos straight back to me via text message, which immediately get embedded into an electronic health record. So you can very much see how that, and although you could do this before, it was really quite clunky. So very quickly you can see if people have a skin lesion they want to share, but also have documented on their electronic health record, that can be done much more easily and quickly than it could have been done even 6 months ago in the majority of practices. And I think the other area I would say is actually I'm in conversations about the adoption of Mendel scanning in other localities where the GP review of the cases is likely to be done at scale across a population maybe of about 50,000 that we flag potential patients up. And we're in conversation about doing, as a lot of these, the next step will be involvement of clinical genetics, but actually doing that as a virtual clinic with the clinical geneticists, and then this one local interested GP or primary care nurse practitioner will be working in a virtual clinic with possibly with the patient or even without the patient deciding on next steps. So I would say primary care is still open. There are positives and negatives to the way we're working, but I think one of the things for many patients, and certainly with patients who are geographically distant, I think it's been a great opportunity. And hopefully we can open up more normally, but still utilize some of what we've learned going forward.
Thank you, Will, and I'm sure that will be reassuring to patients. Okay, now the next in line is Professor Freda Fortune from the London Centre, and she's very kindly put a video together. So we'll show that one now, and then we'll move into the Q&A period.
Hello. For those of you who don't know me, my name is Farida Fortune. I'm the clinical lead of the Behçet Centre in London. I'd like to thank the Behçet's Patient Society for asking me to give a short talk today to cover two topics, the survey and our current clinical situation. I'll only be giving headlines. The paper will be out soon. So looking at the group is comparable to the groups we had previously for age, sex and ethnicity. So what are the major symptoms that have an impact? In 2009, this was oral ulceration, genital ulceration and skin lesions. When we come to 2014, it's changed slightly in that now joints and fatigue become the more prominent symptoms which have an effect on the outcome of a quality of life. In the 220, this is similar, but fatigue is the major symptom, then joints, which have an impact on the outcome of a quality of life. What made the difference, I suspected, was that we concentrated heavily on oral health, instruction and dealing with oral ulceration. And as you know, we also developed a bespoke mouthwash which has had a huge impact. We will need to deal with joints and the fatigue. Fatigue remains a huge problem because even if patients are well, they still feel fatigue. Lifestyle. In all the surveys, the improvement in all of your diet has had a positive impact on quality of life, so that's been hugely beneficial. However, we still have a problem with smoking, although 30% of you have stopped smoking since the last survey, so that's very good, and only 9% of patients now smoke. We have, however, had an increase in the use of cannabis, and cannabis and smoking together have a negative impact on outcomes. In addition to that, we still have mental health being an issue, and so is anxiety. And this year there's been a huge increase in anxiety, which is not surprising. Education level of the Behçet's patients are all mostly above GCSE and higher attainment. This of course has an effect on employability. All the surveys, including this year's, have shown that those who are in employment do better than those who are not working. It doesn't matter if you're in full-time employment, whether you're working part-time or you're volunteering, or if you've decreased your working hours, you still have a better outcome than people who are not working at all. The additional problem is applying for benefits. Even if you get the benefits, your outcomes for your clinical outcomes tend to be slightly worse. Having said that, the positive news is that with the work of the Behçet support workers, most people now will get benefits. So that's usually positive. However, as a group, we've still got to work very hard at making sure that people do get support around finance, because this has a really large effect on clinical outcomes. I'm going to stop there and move now to the current clinical situation. As you know, this year has been hugely difficult for everyone. For patients, clinical services being decreased, and also that a lot of patients during this period have an increase in disease activity. The survey has shown that the triggers for active disease are firstly stress, but equally important is infections and seasonality. As we know that in spring and autumn a lot of patients have had active disease. This year we've had more active disease than would be expected at a comparable time of other years. The patients have all had active Behçet's disease. There have been 3 patterns where they've had COVID-like symptoms which last between 1 and 10 days, and then all the symptoms disappear. There have been the second pattern where patients have had a longer period, combination of active Behçet's disease symptoms as well as active COVID-like symptoms. However, increase in immunosuppression has quickly turned off this activity. And these have been mainly the patients with vascular, ocular and neurological disease. We've had a third group of patients who've had a much more prolonged course of active disease, but I'm pleased to say that most of those patients are come under disease control. However, we're now moving into the autumn and the flu season, and we would expect again to get increased disease activity. Could I ask all of you to think carefully and go and have your flu vaccine? Some of you might also benefit from having a pneumococcal vaccine, and if this is offered, it's a very good idea. However, could you ask your doctor if you could have a gap between having the two and not to have it in the same arm? We've had a few patients who've had a huge reaction around the lesion and have been clinically a bit unwell with it. We know that when you have your flu vaccination or any vaccination, you get a bigger than average response, either locally or bit of activity systemically, but this really protects you from later on in the year, which is in the next few weeks when the flu virus kicks in. I'm sure someone would like to ask what's happening about shielding, and you might have heard, like I did, when Chris Whitty was asked what's going to happen about the patient who is shielding. He said there will be no further shielding. I think this is a very difficult concept for our patients. When you've told them to shield, you're now telling them not to shield. What I would say is those patients that have been told they should go back to work, that at work that it's the employer's responsibility to do a thorough risk assessment. If the risk assessment then says, yes, you can go back to work, it's the employer's responsibility to make sure that you're working in a safe environment and continue to do so. So I would wish everyone well over the coming months. Can I ask you to be as careful as you have done till now? And I think if that happens, we should have a good outcome. Could I say to you that all these patients that had these COVID-like symptoms, not one of them had a positive swab for PCR or had a positive antibody for COVID. So what's happened, it's triggered active Behçet's disease. All the centres are open. We have been open all through COVID, and I'm pleased to say we continue to see new patients and patients with active disease being sent to us from other centres and other hospitals, and we hope we can continue to serve you. As you know, it's quite difficult because we've had decreased staff because staff had been redeployed, and I suspect that that will happen again. But all the centres, including myself, will do the best we can to support you, and we look forward to seeing you all next year face to face. Thank you very much.
Thank you, Farida, very much for that summary. It was very useful.